All right. Well, it says recording. All right. So I guess we'll get started. I'm Leslie Hammond, and I'm with the Home Care Alliance of Massachusetts. And this is our monthly lunch and learn session. Today's session is from Marty Agatha of Embrace Prevention Care, and we're going to go over Medicare's new guide program. All right. Um, this program will be recorded and available on our website, but we will also ask that you hold the questions till the end, and we will be able to connect you with Marty through email. Okay, great. Well, go ahead, Marty.
Leslie, thank you very much, and welcome to your members. We're very happy to have you here with us today. And I'm here to talk a little bit about a new program from Medicare called GUIDE, which is short for Guiding an Improved Dementia Experience. And it's designed to provide care, coordination, navigation for dementia patients who utilize Medicare. And it presents an interesting opportunity for the membership of the Home Care Alliance of Massachusetts to join with us, Embrace Prevention Care, and our guide participant, internal medicine and primary care, to deliver some of these services to your patients. And even if you choose not to participate with us, uh, you can certainly refer your patients into the program to ensure that they receive these valuable care services. So, Guide is addressing a growing need in the community, and we'll talk in detail about that. But it also presents an opportunity for the membership. The whole idea is that we can improve dementia care while reducing costs, and that was the guiding principle behind Guide as it was formed by CMS. Today, there are 7 million patients living in the United States who have a diagnosed dementia of any sort. Most dementia is diagnosed between the ages of 70 and 90. And what we're seeing now is that as the baby boomers age into that population, and they're living longer due to our ability to more directly treat and prolong life for those individuals who have chronic conditions, that we anticipate that this number is going to double in the coming 20 to 30 years. We also know that there's a significant physician shortage, primarily in primary care, but also in the neurological specialties. And so that increases wait times for these patients and reduces the amount of time that they can spend seeing their physicians. Dementia patients have 42% more hospitalizations than other older adults. This is significant because that hospital time, often when patients enter the hospital, they come out and they have decompensated over time and don't come back with the same abilities that they had prior to the hospitalization event. And ultimately, this means that they are no longer able to live at home. CMS has also identified that the typical patient, a patient 65 or older with a dementia diagnosis, costs 3 times in annual costs what an older adult 65 or older costs who does not have a dementia diagnosis. So this is a very significant impact on the healthcare system. And we know that when the patient ultimately ends up in the SNF or potentially at the hospital, the majority of those costs are borne by CMS. And so that's the rationale for providing additional care now. Is if we can reduce the time in the future, that's good for the patients, but it's also good for the payer, CMS, Medicare. So it's an 8-year program that's been established. We're about a year and a half into the program right now. It provides enhanced dementia care for the patients and support for unpaid caregivers. And this is unique. This is, I think, the very first program that has ever addressed the needs of caregivers as well as the beneficiary. So this is a huge change for Medicare, and they're putting money behind that as well. There's no cost to participate for the patient. This is 100% no deductibles, no co-payments, no changes in premium. So it's a real benefit for the patients because they can just get into the program. There's over $2,500 in annual respite care available for caregivers, for qualifying caregivers. This is designed to give them a break, to help them avoid burnout, and ultimately to keep them able to provide that care, which at this point is uncompensated and very valued for both the patient and the system itself. To enroll in the program, the patient does not need to get a physician referral. And so if a patient or caregiver know about this program, they can enroll directly. So that's a huge change as well. This is available to patients who have traditional Medicare. So Medicare Advantage is not, patients are not eligible. We'll have a detailed slide on eligibility in a bit. So there were 300 companies that started in the program nationwide, and Embrace is partnered with one of those. The whole idea is it provides longitudinal care for both the patient and the caregiver. There's care navigation and frequent interactions to address the patient's medical conditions, but also their social issues as well. So that's another huge differentiator in this program. And the idea is to create an interdisciplinary team which focuses on the whole patient, not just the individual silos. So the care navigators that work for Embrace are required not only to work with the patient, but they are also required to inform, keep the other physicians, whether it's primary care or specialty physicians, informed as to what the progress is. And then again, as I said, coordinate with local social resources. We talked about this. There's no cost for the patients, no copays. There's the $2,500 in access in respite payments that are available. And again, the patient can opt in without a doctor's referral. The objectives of the program are to improve patient quality of life, to reduce the caregiver burdens, and prevent and delay skilled nursing admissions. Here are the services, some of the services. There's 9 care services that are delivered. This is a summary of those. So there's a comprehensive, individualized assessment and care plan created for each patient. Support for the caregivers. Again, this is part and parcel to the program. The whole idea is by supporting those caregivers, we can make them more effective and keep them engaged and the patient in better health. There's the respite services, which we've discussed, that can be in 4-hour blocks of in-home time. It can be in adult daycare or overnight services. The coordination and support of care, we talked a little bit about this. This is what the care navigator does, and the whole intent is to work with the patient, understand their needs, help them take care of both the health and social needs as required for best health. The GUIDE program itself does not provide for patient for payments for additional required social services like Meals on Wheels or in-home health care, but it requires us as care navigators to connect the patient and caregiver to those services. Whether they choose to elect those services or not is the decision of the patient caregiver dyad. And then finally, there's 24/7 access for the patient to live operators because obviously dementia is a 24/7 disease. The care delivery components are on the right side of this slide, and how that they map up to the objectives that we talked about, the 3 objectives of the program, is on the left. And this slide explains all 9 of the care delivery services. So the whole idea here is that GUIDE provides integrated health and social care, and that is one of the strengths of the program. And so that comprehensive assessment, the healthcare side of it, provides the clinical dementia and behavioral assessments, and uh, the social care is health-related social needs, caregiver assessments, and you can see in this table how these play out. But what we the purpose of this presentation and what we want to propose to your agency is the fact that depending upon your capabilities, you can provide some of these services on our behalf, and we are able by CMS, the CMS contract, to pay your agency to provide those services. Leslie, do you have any questions at this point?
I guess if you want to talk a little bit about what is the right type of agency that can benefit from GUIDE?
Sure. So we believe that most agencies are going to have patients who can benefit from GUIDE. And so connecting a patient to a GUIDE program is in the best interest of the agency. If the agency wants to leverage their current services and can work with a GUIDE provider, so I'm sorry, GUIDE participant, they can provide some of those 9 care services on behalf of the GUIDE participant and receive compensation for that. For the agency that would fit, it would be an agency that was looking to perhaps expand their service offerings or potentially utilize a single visit to accomplish multiple tasks. So, for example, one of the requirements of GUIDE program is to do a social needs assessment. And if the agency were to be out visiting the patient as part of their normal services, they could do that assessment at the same time. Or perhaps another service is a home safety inspection, and they could do that while they are on site. So this is a way for these agencies to participate in GUIDE and be compensated for those efforts. If any of your members provide respite services, that's another avenue. However, just being 100% frank, the respite payments are the rates are determined by Medicare, and what we have heard nationwide is that those rates are fairly low. That being said, we've signed a number of agreements in Massachusetts with respite providers because those providers realize that this is it's an opportunity for basically business development. Any further questions?
Not really. Not
Okay.
oh, keep going.
Absolutely.
All right.
So in terms of the care delivery process, the GUIDE participants applied to CMS in January of 23. 330 were approved nationwide. 16 of them are providing GUIDE care in Massachusetts. So these would be organizations with which your members could reach out to determine whether they're looking for partners. As I said, the agreement was the participation agreement was strictly intentionally designed to encourage these partnerships. So this creates the opportunity for your members.
Okay.
So again, GUIDE participants, that pool is closed. there's only 330 nationwide, but guide partners, and this is what your members would apply to become with a participant. Guide partners, those applications are being accepted now. So if one of your members, creates a relationship with an organization that is providing guide services, then they could apply for and be approved as a guide partner. So, as I said, you can apply to CMS. That's done by the participant, not the partner themselves. And this is an interesting piece. Your members could partner with multiple participants. So they could choose to work with us and 2 other guide participants in the state. And each participant is going to define the partnership arrangement between your member and themselves. So that's one sort of cautionary item, and it'll require sort of individual negotiations with each participant partner. I've got this list of the guide participants who are providing care. And Leslie, I would be happy to send this list to you after, so you can include that in the link here.
Great.
Okay.
And tell me a little bit about the partnership. Is it time limited? Is it, forever?
That's going to depend upon the individual participant. Our partnership agreement has no time limits. It's designed to scale up or scale down as the partner wishes. So we can start out with a very basic partnership agreement where we would, only be partnering for in-home safety assessments, and we can grow that over time depending upon the needs and desires of the partner. At the highest level, and this is at the highest level, the partnership, envisions quite a bit of interaction between your members and our team. So, and we compensate appropriately for that. So,
have you had any issues or any hurdles that you've had to overcome?
Yes, to be frank, in Massachusetts, and of course, unfortunately, and I didn't say this earlier, Embrace is providing guide services in 6 states at present. In Massachusetts is a little bit unusual in that in-home, you may correct me on this because I'm not 100% up to speed or know the details, but my understanding is that in-home care, those people do not have to be certified by the state. Is that accurate?
To get the licensure for the agency.
Yes, the licensure for the agency, but not the individual.
Hmm.
Is that correct?
I'm going to defer to a clinician.
Okay, that's fine. So the reason I bring that up is that because those individuals are not licensed by the state, we have to make sure that that our partner agency keeps track of which individuals visited the home on which specific dates, in the event that we are audited by CMS for that.
Okay.
But other than that, there have been no hiccups to this point.
So really the guide program's emphasis on like care coordination and caregiver education, the respite services and care navigation. But it's not necessarily hands-on care. Is that right?
That is correct. It does not have so the program was designed such that it can be 100% virtual.
Okay.
But the typical care, in-home care provided by your members is outside the scope of the services provided by Guide, beyond the fact that we need to connect the patient to those services. But there is no financial help for that unless the in-home party is doing a respite visit for the caregiver.
But you see this as a like a marketing piece too, like how to differentiate yourself from other home care providers in the space.
That is absolutely correct. And our commitment to your members when you partner with us is that patients who come to us outside of the relationship with your member, if they, as we work with the patients, when we identify the need for the services that your member can provide, we would connect that patient to your member. So a net new client. For those clients that are already working with your with their patients, if they refer that patient into us and the need for their services ends, if that need shows up again, we're going to refer that patient back to the agency that referred the patient into us in the first place. So we're going to make sure that link is sticky, rather than them, at a future date saying, "Oh, I need help. I need some assistance," and they find a different agency. So our job is to make sure that they connect back to the agency that brought the patient to us.
Excellent. Thanks.
All right. So, as I said, your members can generate revenue from guide services for these specific things, doing those comprehensive assessments, home safety assessments, and providing respite care. And they can also generate the new referral or generate new revenues from the referrals from the people. That's what we just talked about.
Okay. So I just to devil's advocate, what risk does the guide partner take on? Like what risk is being pushed to the home care agency?
The biggest risk would be, and I probably am not the best person to answer, would be our ops team, but the biggest risk in my mind would be that they are not going to be audited by CMS, but the participant will be audited, and that may require reporting from the home care agency, as that audit takes place.
Right. Right. Well, I don't have any other questions. If that you'd like to finish up, and I'll definitely get this recording out,
Perfect.
posted, and we'll maybe put a little bit in our newsletter in case people have questions.
Excellent. So, if we're talking about how to refer patients to guide participants, as we said, there's no referral required from a patient. So if one of your members has identified a patient that could benefit, they can just look at referring that to a guide participant. For patient eligibility, and again, we don't look to your members to confirm all this stuff, but this just gives you an idea of what the eligibility criteria are. They've got to be straight Medicare. They can't be in a Medicare Advantage program. They need an existing diagnosis of any form of dementia. So the big one we know about is Alzheimer's, but there's over 100 dementia diagnoses. Living in independent or assisted living facilities is okay for this. I attended a webinar with the leader of the program from CMS, and they were very surprised at how many people were actually, this was their living arrangements was in independent or assisted living. If they have been in skilled nursing for 100 days or more, they are ineligible to participate. However, if they are in skilled nursing as part of rehab, as a short-term stay, that's okay. They are eligible to enroll or to continue participating in guide. And finally, they cannot be enrolled in hospice. So you can refer to a local guide participant. As I said, I will share that list with you that shows all of the local guide participants. The challenge, frankly, with guide today is guide participants are required to provide services in zip codes that they individually select. If a patient resides in that zip code where a guide participant provides guide services, the guide participant is required to take the patient. The idea here is that this program was designed with health equity in mind, and so you must take patients who are in your zip code. The flip side, in the zip codes you've selected, the flip side of that is that if you didn't select a zip code, then you are not able to service that patient. And the idea is because we need to build these care networks of additional care providers for the care services. So, and once the patient is aligned to the program, so we do the initial assessments, we get a diagnosis of dementia, we submit that to Medicare, then the guide services start. The typical time frame is from 4 to 8 weeks for that to take place. All right, so here's sort of what makes our program a little different than many. We have been focused on older adult preventive care via telehealth for over 4 years now, and that has reduced hospital days for our clientele by over for our patients by over 40%, as compared to similar adults with similar disease loads in the same practices. So what we do is we work with an interdisciplinary team that consists of a local NP, that's our care navigator in guide language. We have social workers, we have a medical director that oversees each of our states, and then we have geriatric pharmacists who provide medication reconciliation, prescription, deprescription advice. We don't do any of that. We work with the PCPs and or specialists on that. So we partner with the patient's physicians. We use the geriatric principle of what matters most to the patient. The whole idea here is that we want the patients to become engaged in their own health care. Healthcare is not something that happens the day that you go to the clinic and see your physician. It's what you do day in and day out at home. And so we use what matters most to the patient to as a goal to help them work with the difficult things we ask them to do, because often what we're asking them to do is lifestyle changes, change your diet, exercise more, those kind of things. We do monthly calls, at least with the patient. We assess their highest risks of hospitalization, and that's what we focus on. And we get them to take 1 or 2 healthy actions. And as they build habits, healthy habits, then we move to new healthy habits or new healthy actions that they should be working on. So if your members wanted to start, I would suggest that we could talk about, directly providing some of those guide services we talked about. Home assessments is an easy start. If they provide respite care, that's another opportunity. As I said, rates are governed by CMS, and we are happy to talk with you about that. As your comfort with the services grows, as I said, the contract is designed to be flexible. You can grow into additional services as it makes sense. That may be the comprehensive assessments. So that would be a cognitive assessment, a burden index for the caregiver, social needs, as we've talked about previously. And then some of your members probably have pretty sophisticated caregiver support services, and caregiver education is definitely an opportunity for that as well. And then finally, transition care in the event that the patient does need to go to the hospital and come home, there are opportunities to work there. And then finally, the last and the biggest is participating in care navigation and replacing some of the Embrace employees in doing that. That's a fairly broad arrangement, but we do have one care partner in Massachusetts that has agreed to do that and is working. So for next steps, I would suggest that if any of this sounds interesting, that you would contact your local guide providers, determine where they work and how that matches up to where you're able to provide services. So do those guide participants, are they willing to partner? What services would they like you to be responsible for? Will they refer back to your agency? Because that would obviously, that's an opportunity for you to generate new revenues. Determine whether or not that makes sense. And if it does, then you can begin to refer patients to other guide to those providers. At that point, you're going to need to complete the partnership agreement with the participant or participants that you've selected to work with. And that's it.
Great. All right. Thanks, Marty.
You're very welcome.
We'll get this recorded and posted, and I'll include a link to it in tomorrow's newsletter.
That's fantastic. Thanks, Leslie. I appreciate it.
Bye.
Bye-bye now.